going to talk about today is anatomy of the knee, ligaments, cartilage, bone, physical exam of the knee, and then grading systems and classifications. So what is a ligament? I'm sorry, I didn't hear you.
Next bone.
Is that the only definition, the only part of it? What else? Okay. Anything else that makes a ligament a ligament? What's that? Okay, you're getting there. Next. So a ligament is a band of tissue that connects a bone to another bone, not to the same bone, and and crosses a joint. So there's no such thing as a ligament that goes from the femur to another part of the femur. If that makes sense. It has to cross a joint to be considered a ligament. And because of that, it doesn't move, it doesn't contract, it doesn't move. It gives a joint stability. So it's a tissue that connects two bones and crosses a joint. Comes from the Latin ligare, which means to bind or to tie. So ligaments inside of a joint, such as the ACL, tend not to heal when torn. Ligaments outside of a joint, such as the lateral ankle ligaments or the MCL, tend to heal, and that's without surgery. I mean, and that has to do with the kind of the toxic environment of the synovial fluid that has the enzymes that don't allow a ligament to heal. So if the ACL is torn, that's why we typically talk about the ACL not being able to heal up on its own. If the MCL heals, it's outside of the joint, it's extra-articular, and therefore it does a better job of being able to heal, or at least has a chance of healing, depending on the types of tears. And then we get into subclassifications, things like that. Lateral ankles, that's why those are ligaments that give a joint stability, but we talk about 90 to 95% chance those heal up on their own, and that has to do with where they are located outside of the joint. So let's just go through the anatomy a little bit pretty specifically. Start off on the medial side of the knee. So here we can see ligaments that tend to cross a joint and give a joint stability. We've got the superficial MCL there that starts from the medial epicondyle of the femur, goes down distally about 6 centimeters down to close to where the pes tendons insert. The posterior oblique ligament, just working our way back. Here you can see the semimembranosus, which is a tendon because it connects the muscle to the bone. And that has the semimembranosus actually has 6 different attachment sites to the posterior aspect of the tibia and knee, even to the meniscus and capsule. So then the MPFL, what does MPFL stand for? Okay, because we have other people, you will need to speak up when asked. And what does that connect? So it ends in ligament, in L ligament, so it must connect 2 bones. What 2 bones does it connect? Yep, there you go. So it connects the patella and femur and gives that joint, the patellofemoral joint, stability. Now look at that thing on the bottom left there. It's called the patellar tendon. What is that connecting? So where it says patellar tendon, what is that connecting? Right. So I'm confused. We just finished saying a ligament it connects a bone to another bone and crosses a joint. And if it connects a muscle to a bone, it's called a tendon. Why is that called the patellar tendon? Yes, but it actually, if you look at it histologically, it's actually a ligament. So it's it has all the characteristics of small fibrils of a ligament rather than large fibrils of a tendon. And so in most anatomy books, textbooks, it'll be called the patellar ligament. So the quadriceps tendon comes down from the quadriceps muscles, it goes into the patella, then the expansion or the extension of that becomes the patellar ligament or patellar tendon. And we can use those terms interchangeably. So what's the AMT up there? I'm sorry, I didn't hear you. You've never heard of an AMT? So it's the adductor magnus. And so that's going on to the adductor tubercle. And you can see where all these come into somewhat of a confluence, where the MPFL goes, where the superficial MCL goes, where the adductor magnus goes into, and they're all in that same area right at that epicondyle of the femur. MPFL goes a little bit posterior, a little bit proximal to the superficial MCL, and that's where you get your landmarks. Adductor does the same thing. That makes sense? So a lot of information on that one slide, and it's a good thing to go back to. The posterior oblique ligament is really just an expansion of the capsule back there. Same type of thing. So here we can see a slightly different view in the next layer, the superficial MCL, proximal distal posterior oblique ligament. You've got the adductor, this medial head of the gastroc there, and the semimembranosus coming down to the posterior oblique. The deep MCL components are really just meniscofemoral and meniscotibial components, and so this really gives the majority of the stability to the medial side of the knee is the deep MCL. You can tear your superficial MCL and you have some instability, some laxity, but until you tear your deep MCL, you're really not going to get that gross laxity. And really the deep MCL components, we show it going from the femur to the tibia, but it becomes contiguous with the meniscus too. So it can also be considered the meniscofemoral ligament and the meniscotibial ligament, which is what is anchoring the meniscus to the femur and the tibia here. We'll go through that in a couple slides. Does that all make sense? So here we're seeing similar stuff, but now identifying some of the muscles, the vastus medialis on the medial side there, the AMT, the semimembranosus, medial head of the gastroc, that MGT, anterior arm of the semimembranosus, direct arm of the semimembranosus, medial gastroc, popliteus. What's the popliteus? Holy smokes. Is that a ligament, tendon, muscle? What is it? So, which means it has a very good tendon. And so what does the popliteus connect? So tendons are connected bone to muscle, right? So the popliteus is connecting what to what? Where's its origin? See how you guys are whispering.
So we don't want to guess. We don't want to guess.
Guess in front. Mom, you're embarrassing me. So the popliteus will start actually on the lateral side of the femur and wraps around and becomes this really big, broad expansion over to the medial side of the tibia. And that's why on this medial picture, you're only going to see that big, broad expansion of the popliteus. When we do these lateral extra-articular reconstructions, we're really just connecting a band, but so it's not a true anatomic reconstruction because that popliteus is such a big, broad fan-like expansion on the medial side of the tibia. So now you got to start correlating this with some of our MRI findings. This is just a quick example of one, but you can see where that meniscotibial ligament down here is my arrow on there at all?
No, if you click on pen.
The pen, okay.
And laser pointer.
Ooh, laser.
Whenever you like to.
Okay, so you can see here where that meniscus is no longer attached to the tibia. That can be considered deep MCL or meniscotibial. And again, this area up here is also going to be up in the meniscofemoral area. Same thing on this side of the knee as well. So you can start identifying or correlating what you know about anatomy with what you're seeing on these MRI pictures, which is not the point of today's talk to go through MRI findings. That's what we got. Whole different aspects for you. So on the medial side, you've got the superficial MCL, the deep MCL, which can be broken down to meniscotibial, meniscofemoral, the posterior oblique ligament or POL, and the medial patellofemoral ligament. Let's go anterior now. So again, we talked about the quadriceps tendon being a tendon. It connects what to what? Okay, so what muscle is the quadriceps tendon connecting? Okay, and what bone is the quadriceps tendon connecting to? Yeah, so quadriceps muscle to the patella. So now you've got the patellar tendon or ligament, and you can see it's actually separate. It's got a little fascial sling over the top of the patella. When you operate, you can open that up, but you can take all of this out, and the quadriceps tendon is still attached to the patella, you can take all of that out and the patella is still attached to the tibial tubercle. Therefore, you know it's a separate entity all by itself, and that makes this an actual ligament. So that's why you might have been able to predict that it would look histologically more like a ligament than a tendon. So a lot of stuff that we grew up knowing that it's called patellar tendon. Sometimes you just got to think about, okay, why is that? So this is what you might see when that MPFL is torn, and this might be the last time I'm giving you guys the answer before we start quizzing, but you remember this is an axial cut, so here's the patella, here's the femur or trochlear groove right there. You can see it sitting subluxed there, and that means that this ligament that was attached here on the medial side of the patella connecting over to the medial side of the femur has to have been torn, and here's an MRI picture of that same thing. In this picture, it actually looks like it's sleeved off the patella as often as not, or more commonly, it's taken off the femur, and often a combination of the two, and it's just blown up. So here's the lateral side over here, that black stripe, which is basically the lateral patellofemoral ligament connecting the patella. Why don't we hear about that so much? Why do we hear so much about the MPFL, but we don't hear about the LPFL all that much? Or why doesn't that get torn? I just said that. I said, why though? Has to do with the way we're put together, our anatomy. What's our normal alignment is about 3 degrees of valgus. Women are more like 7 to 8. Guys are in that 3 to 5 range. And so just being in valgus, there's really 5 anatomical reasons, but that's the biggest one why the patella might dislocate laterally rather than medially. If you're in some valgus, it's really hard for that patella to dislocate medially. It's got to be a really unusual and transient force. Plus, the lateral side of the trochlea here is higher than the medial side, so that's acting as a little stopgap. Plus, the rotation of the tibia is a little bit internal. There's internal tibial torsion. That's why people walked, especially athletes, walk a little bit in towing, and that's also keeping that tibial tubercle in place there. Does that make sense? So this is just what we talked about there. And you see on my talks, what I do is say, this is what we're going to tell you, this is what we told you, and then we're going to quiz you on what you did, what we told you. So it's probably good to. So here's posteriorly. And what do you see here posteriorly? Why don't you give me a couple of things that you see there?
Posterior.
How about this right here? What's this? It's labeled, so I'm giving you easy. All right, so now you can see where the tendon attaches to the femur on the lateral side of the femur here, over by the lateral collateral ligament, or FCL, and then wraps around to this big broad confluence. And like I said, when you'll see some of these reconstructions this year, where we're going anatomically here because it's a discrete bundle there, but then we just go in right about here into the tibia and bring it forward. So we're really not recreating it's a ligamentous reconstruction for a tendon for all intents and purposes. So. And there's popliteal-fibular ligament that's holding that in place so that it doesn't dislocate. What's FCL stand for? What's that? Very good. Also known as the lateral collateral ligament. What's this over here? Yeah, so posterior oblique ligament. Remember, we saw that on the medial side. This is really in the back, and it's kind of a confluence of that meniscofemoral, meniscotibial. A lot of these become contiguous with other parts, and it can actually be considered a part of the capsule there, but we call it a ligament because the capsule, as you would know, goes from a bone to a bone and crosses a joint. So what's this right here? Right, and where does that go from where to where? Yes, yeah, essentially. So, and what's this right here, that little thing? What's that? Right, posterior meniscofemoral ligament. So it's what actually helps anchor that lateral meniscus to the bone here. because there's a lot more play in the lateral meniscus than there is in the medial meniscus because of that opening of the popliteus, because it can't get anchored there. So not only does this meniscus get anchored to the bone there, the posterior root, but it'll also get anchored to the bone up here, both in front and behind the PCL, which is what that ALB is. That makes sense? So here's again the where you see the FCL or lateral collateral ligament right there, and that's where the popliteus takes its origin from, a little bit distal and anterior to the LCL origin in that little kind of hiatus or kind of sulcus in the femur. Now you see the ACL looking at you from the front. Here's the PCL now. This is another one of those meniscofemoral ligaments, but now, as you've said, the other one from the back is the ligament of Rissberg. What's this one? What's this one? What's this one? Anybody? Bueller? Yeah, just anterior to the PCL, the meniscofemoral ligament. What's that called? Anybody? Bueller? If this one's Rissberg, what's this one?
Raise.
There you go. So you've got the ligament of Humphrey, which is runs in front of the PCL, and the reason it needs to stabilize the meniscus, and the PCL gets in the way of having that that meniscus to the femur anchor point, so it kind of splits, and the front part is called the ligament of Humphrey, the back part is called the ligament of Rissberg, but they both go from the meniscus up to the femur. Make sense?
Think about it alphabetical. Anterior is H, posterior is W.
Yep.
H becomes before. That's how I finally remembered it.
Yep. You'll definitely get asked about that in the OR when we're staring at normal anatomy arthroscopically. So again, posteriorly, here we go. The FCL or LCL, we've got the PCL that you can see there, tibial expansion of the posterior ligaments. Here's the popliteus tendon or ligament as it wraps around. So there's a lot of layers of the anatomy, and it's just important to understand at this level what a ligament is, what a ligament does. It's not expected that you understand every layer and every piece of tissue. The four big anchoring ligaments, the MCL, PCL, LCL, and ACL are important to understand that. And then after that, we get into a lot of these smaller ones. So PCL is the oblique popliteal ligament, the popliteus, the meniscotibial capsular expansion, and then the posterior oblique on the medial side. Lateral side is a lot more complicated, which is interesting why it would be, because it really doesn't make a ton of sense why that would be more complicated, because we're all born a little bit valgus and much more common to injure the medial side than the lateral side because of our the way our anatomy is put together. And if you're going to rotate, or if you're going to twist, or if you're going to get hit from the side, you're going to rip up the medial side more than the lateral side. But there's a lot more different structures in the lateral side. So now let's get into the lateral side. These are all labeled, so I'm making it easy on you. Go ahead and identify what do we got here. Also known as, there you go. And you can see where it goes on the lateral femoral epicondyle up here. Down in that little sulcus there it would be the origin of the popliteus. Here it shows it a little bit more anterior than it probably is. It's just slightly distal, slightly anterior to the origin of the LCL. This is the popliteal fibular ligament, so it goes from the fibula over to the tibia to just anchor that down so that this popliteus doesn't dislocate in front of the fibula or anything, or lose its way. So lateral head of the gastroc, remember we saw the medial head of the gastroc. We're not focusing on tendons here, but the gastrocs tend to be different from the soleus in why, how. So the Achilles tendon, we're not doing ankle today, but the Achilles tendon, I'll just give you this, is the confluence of the gastroc and soleus tendons, correct? You guys already knew that. So how do the gastroc and soleus, so they take their insertion are the same point into the Achilles tendon. So how are the origins different? Are you sure about that? So it's easier than that. So the gastroc crosses the knee joint, whereas the soleus does not. So So in reality, in terms of your plantar flexion of your ankle, your soleus is going to be a much more, anything that's a one joint tendon or muscle is going to have much more power to it than a two joint tendon. So the fact that the soleus crosses the ankle joint only, and the gastroc crosses both, then that means that the gastroc is going to be much weaker in terms of your ankle flexion. Does that make sense? So, so this is just goes to show some of those reconstructive options that we talked about and where we put these things. But you can see your FCL graft, and then if we do the lateral extra-articular with the where we put the popliteus, and again, you're not going to recreate this whole big bundle of that expansion. Much like the PCL, why it's not as anatomic, the PCL insertion on the femur or origin on the femur is a big, broad expansion, whereas the our reconstructions are all band-like. So here we go here to identify something that we haven't identified yet. Okay, what's that? Okay.
Some think that it's not really a ligament, they think it's just a thickening or a capsule, whereas others are like, no, it's definitely a ligament.
You know, yes and no. It is a discrete ligament. It's not the most robust of ligaments. You can dissect it out and isolate it like this. When we see a Sagund fracture, what's a Sagund fracture? Often or always? Always. Always. So if you see all of Sagund fracture is that ALL attachment to the tibia pulling off that fleck of bone. So if you see that fleck of bone, you've torn your ALL. The ACL will tear before the ALL will tear. Therefore, it's going to be pathognomonic for an ACL tear if you see that Sagund fracture. So yes, it's an expansion of the capsule, much like the meniscotibial, much like the meniscofemoral are expansions of the capsule, much like the posterior oblique ligament is an expansion of the capsule. Because remember, these tissues cross a joint and connect one bone to another bone, which is what capsules do, which is what ligaments do. So in the shoulder, for example, the shoulder capsule is called the anterior inferior glenohumeral ligament, because that's what it is. It's the capsule, but it's also a ligament that gives our shoulder stability. So we tear that when we dislocate our shoulders. So capsules are much more akin to ligaments than tendons are when you look at them histologically under a microscope. Does that make sense? Mm-hmm. So here's when we were talking about how complicated that lateral side is. This is not for level 1 of ATCs going into this training, but just understand that there's 3 different layers, much like there is on the medial side. They're just a lot more complicated on the lateral side. And like I said, why it needs to be more complicated on the lateral side from an evolutionary standpoint does make a lot of sense from an injury standpoint, but it has to do with how much rotation we need in the knee, which isn't a ton. We don't need it. We need to stop it. So lateral side, we talked about LCL and FCL are interchangeable. Arcuate ligament complex, which is popliteus, velo-fibular, and that whole arcuate ligament complex is that expansion of the capsule out there. And then the ALL or anterior lateral ligament. Internal ligaments. Now we're getting into the juicy stuff, aren't we? So what do we see internal ligament wise there? Okay, what is that? What do those stand for? Okay, so where does the anterior cruciate ligament go from where to where?
Anterior.
Okay, so it goes from, I think I heard you say posterior femoral condyle to the anterior tibia. Where does the PCL go? Okay, but use your words.
So the medial posterior femoral condyle to the
Oh, you're so close. That's why I make you use your words. So where does the PCL go from where to where? Yeah. So the ACL goes from the posterior lateral femoral condyle to the anterior medial tibial plateau, PCL. So since it goes from the ACL, let's just pick on that for a sec. Since it goes from the posterior lateral femoral condyle, why the heck is that called the ACL? So yeah, these are both named based on where they insert, not where they take their origin from. So, and that can get confusing early on at your level when you're just learning all this anatomy. They're called cruciate because they actually do cross. They don't go straight in line. You can see they form a little bit of a cross. And you can see here also that the PCL inserts or takes its origin higher on the femur than the ACL does. ACL is a little lower on the face of the clock, if you will, of that intercondylar notch. PCL is up a lot higher. If you can think about the center of that PCL being more like 10 or even almost 11 o'clock, ACL is going to be much lower, around 2:33 o'clock down here at the center. But the ACL has its insertion on the anterior portion of the tibia. PCL has its insertion on the posterior aspect of the tibia, and that's how they get named. Make sense? It's confusing. So, and these are all the internal ligaments as well as the external ligaments that we've talked about. And this is a good slide for you guys to kind of take away all the labeling and just quiz each other on, just point to this, what's this, what's this down here, what's this bony, what's this part of the bone here, what's this out here. But you should be able to get to the point just in these first few weeks where this is just second nature. You can point to something and immediately be able to tell us what it is. So this is the view from the back. All right, PMFL, what is that again? I forget. Okay, so which has another name of?
The ligament.
Oh, you're so close.
Oh, sorry, Wisberg. We're posterior. I'm sorry, Wisberg.
Right. So, right. So here's this is the PCL, and then the kind of the lateral cartilage, posterior aspect of the cartilage. And when we see these tibial plateau fractures associated with ACL injuries, they're always way back here, so not really on the weight-bearing surface, but indicative of cartilage damage nonetheless. Does that make sense? So here's what kind of defines why they're posterior and anterior as well, is that an anterior translation of the tibia will tear that ACL, posterior translation of the tibia will tear that PCL, and that's what they're doing right there. Much more complicated than that, but that's might be an easy way to think about how they run. So we can even get into, by Christmas, you should know this like the back of your hand, two different bundles of the ACL, anterior medial and posterior lateral. That's not for today's lesson. And where each bundle takes its origin, where each bundle attaches to, and what each bundle does, which that gets defined when you know when they're tight. In other words, the fact the posterior lateral is tighter, closer to extension, anterior medial is tighter, more inflection, tells you that's where they're providing supporting structures. Anterior medial is actually going to be loose, and when we're in 30 degrees of flexion, and that's where we do most of our sports. We don't do sports in 90 to 120 degrees of flexion, which is why that posterior lateral becomes more important for the sporting activities that we do. As we get into deeper flexion, we're constrained by the bony architecture too. And this just goes to show that as we get into flexion, which one is tight and which one is relaxed. So these will be good. This arthroscopic, diagrammatic from inside, the diagrammatic from larger view. So getting to know this and seeing it arthroscopically as you're all getting into the operating room with us It really does create more of a light bulb. As you can ask people, can you point out the anterior medial? Can you point out the posterior lateral? Show me where this is tight in flexion. Show me where this is tight in extension. And you really can see it dynamically. And once you see it dynamically, it's a lot easier to understand. So, like we said, posterior lateral, anterior medial on the ACL. PCL is named differently, posterior medial and anterior lateral. And then meniscofemoral, you've got Humphrey and Risberg. So what's cartilage? We've talked about ligaments, we've talked about tendons so far. What's cartilage?
It's the actual joint surface. Where like two bones meet to form a joint, it help protect and allow for smooth movement.
Getting there, getting there. Without getting into the different types of collagen fibers in cartilage, which we'll define this a little bit better, there's two different types of cartilage we talk about. What are the two different types? Okay, that's one. What are the two? What are the two?
Meniscus.
Yeah. So there's meniscus cartilage and there's articular cartilage. It's confusing because patients will always come in and say, I tore my cartilage. And you might get dialed into articular cartilage being the more important part of the cartilage, but patients more commonly will understand meniscus as being cartilage. They don't even necessarily understand what articular cartilage is, but both of these are named cartilage. It's unfortunate because it does create a lot of confusion if they had different names. One was just meniscus, one is just articular surface or something like that, but they're both called cartilage. You need to understand that. And that has to do with, what makes one and one the other has to do with the type of collagen fibers that are involved in each, which is way beyond what we're doing here. So the meniscus is a C-shaped ring of cushion between the femur and the tibia. It's attached to the capsule via the soft tissue attachments all around through that full C that we looked at, the meniscotibial, the meniscofemoral. Those are all just capsular expansions. And you can see we're naming things in several different ways for the same type of tissue. So the capsular expansion is also a meniscotibial ligament, and just get to know that can lead to a little bit of confusion. But you've got meniscofemoral, meniscotibial, and that's how that meniscus is attached to the joint and holds it in place, with the exception of its being anchored to the bone in the front and the back, and that's called the anterior root and the posterior root. So it dives down and is attached to the bone. So you've got this C-shaped ring that's held in place, or held in the shape of a C based on the collagen type of fibers and tie rods that we have in there that you'll learn about down the line. And then it's anchored to the bone anteriorly and posteriorly, but nowhere else. It's not anchored to the bone throughout the rest of the ring. It's just in front and in back, and then it's attached to the capsule throughout the other way, the rest of the joint. And that's why the lateral side has much more motion or less stability because that popliteus that goes right through there, and it's not firmly attached to the popliteus, or you would tear it with every time you moved your knee. So the articular cartilage we often refer to is just a cap of low friction paint that covers the end of the bone inside the joint. When you look at the end of a chicken bone, it's that smooth, shiny, glossy stuff at the end of a joint, and every joint has some articular cartilage covering it, and that's what gives us that gliding surface. In the larger joints, such as the knee, such as the shoulder, such as the hip, it's usually about 5 to 7 millimeters thick of this cap of low friction paint. 5 to 7 millimeters. How many millimeters is an inch? You're going to have to get really, really good at these conversions because you've lived your life on the American imperial system, and medicine is on the metric system. So we're not going to talk about that, how many inches that it's thick. We're going to talk about it being 5 to 7 millimeters. So you need to know, being able to describe it to patients, how many millimeters is an inch. Don't go looking it up. How many millimeters is an inch? No idea? Okay. 60 millimeters to an inch? Okay. Okay, 25 millimeters is an inch. Yeah, so I could be wrong.
No, you're
I'm
right.
sure I trust you.
Oh, thanks.
25.
It's 25.4. So 5 to 7 millimeters thick is how many inches? It's about a quarter inch. Yeah, so for it's about a quarter inch thick of this cap of low friction paint. It can wear down like the treads on your tire. You know, if your tires get 30,000 miles on them, they're worn out, and you haven't done anything wrong. You haven't run over a nail or anything else. They're just plain old worn out, and that's why we're seeing all these guys my age with worn out cartilage because they put 30,000 miles on their tires, not because they did anything wrong or had injuries. Now, second way you can do it is to injure it, and you can chip off some of this paint. And so this is looking at both articular cartilage and meniscus type of cartilage. The meniscus can tear because it's a cushion like a sponge, and when you feel it, it feels actually very similar to the little knee models that we have in each of the exam rooms. It's kind of spongy. Oh, geez. I can't answer you right now. Whereas the articular cartilage, you can see here, this is not a wear and tear phenomenon, this is an injury phenomenon. And so you need to be able to describe when you're telling us, is it a wear and tear and it's just a thinned cartilage, or is it damaged cartilage? And there's a lot of overlap that you can have thin cartilage that then gets damaged. So here's what we talk about. These are MRI findings, and you can see that gray is the thickness of the articular cartilage on an MRI. This is fibrillation that's not down to bone. This is a fissure that is down to bone. And this is some delamination where that's where it should be attached to the bone, and it's not. So it doesn't look so bad on this MRI finding, on this MRI, but if we go in there and probe that, it's peeling off like a banana peel. And that's why the delaminated areas are much more concerning than a fissure or fibrillation. Does that make sense? So these are different types of tears of the meniscus, and you will get asked that when you're in the operating room with any of us knee guys. Give me 5, 6, 7 different types of meniscus tears. Articular cartilage, the grading scheme. This was originally described by a guy named Outerbridge out of England back in 60 and 62. And it was described more for wear and tear type of issues, but it's been used for articular cartilage injuries now too. And it's been used throughout the body as the 0, 1, 2, 3, and 4. So 0 is just normal. 1 will be have some softening or even a little blistering. So what might a grade 1 articular cartilage damage look like when you're just looking at it through the scope? Can you see soft? Right, but what will it look like when you look in there? That's normal. So it looks normal, and so you can't see grade 1 changes. You can probe it and find softening. You can probe it and find that it might be blistering a little bit, but you can't see softening. And that's why it's sometimes funny that it's often funny that our radiologists will call it grade 1 softening on an MRI, which you can't see softening. Now, they can tell that it's grade 1 because it's abnormal and it's lost some of its water content and things like that, but you can't see softening. But grade 1 is just going to be soft, blistering. Grade 2, and this again, that Outerbridge classification, fissuring that's not down to bone and fraying of less than 15 millimeters in diameter. So if you have fissuring down to bone or fraying without exposed bone of less than 15 or of greater than 15 millimeters in diameter, it makes, that's a misprint there, of greater than 15 millimeters, that would make it a grade 3. So either one of those two make it a grade 3. Grade 2 is that both of those have to be true for it to be a grade 2. If it's fissuring not down to bone, but you have fraying that's greater than 15 millimeters, then that makes it a grade 3 already. So it's got to be both of those to be a grade 2. Grade 3 is if either one of those are true, it becomes a grade 3. And if you have any exposed bone, let's say you have a 17 millimeter in diameter fraying, but in just a 2 millimeter corner of that, you've got some exposed bone. That makes the lesion a grade 4 lesion. You're defining it by the worst of it. So you will be asked when you're reading these MRIs or reading the MRI report, what grade is that articular cartilage damage? So we tend to refer to this more to damage than to wear and tear, but it can apply to both. But so when you're presenting something, then you might say this grade 3 lesion of the medial femoral condyle because it's about 20 millimeters, but no exposed bone. So again, we'll get into what we talked about before with physical exam. We go through our normal, and we'll just keep hammering this on every joint of the body, hopefully inspection, palpation, range of motion, strength testing, and then specialty exam. So what's the difference between swelling and effusion? And effusion specifically refers to swelling within the joint. Swelling, that whole knee could be swollen, and if the whole soft tissue, if you palpate it and it's just soft tissue but not inside the joint, then it's just a big swollen knee. If part of that is inside the joint, then it's swollen, but it has a large effusion. So understand that effusion is a subcategory of swelling. Swelling is very general. You want to note any color changes, right versus left. You want to note any atrophy of the muscle. You want to note any abrasions. And then inspection is actually part of gait analysis too, is you want to look at antalgic versus Trendelenburg gait, which I don't think we'll get into too much here, but that's a great talk to have. And so you're inspecting their gait. So if they're coming in with an acute problem, we typically won't have them walk for us. If they're coming in with a chronic problem, it's been hurting for 15 years, we'll usually have them walk up and down the hall, or we'll inspect them as they're walking back and forth from x-ray. Just real quickly, what's the difference between what is an antalgic gait? Yeah. What's an antalgic gait?
It's just, it's an abnormality in the gait resulting from pain.
Correct. What's a Trendelenburg gait? There's a much better way to describe it. So it's an abnormal gait secondary to muscle imbalance. Okay, so an antalgic gait is an abnormal gait secondary to pain. Trendelenburg gait is an abnormal gait secondary to muscle weakness. So how can you just briefly, how can you tell the difference between an antalgic gait and a Trendelenburg gait? Just watching them walk down to the x-ray. Write this down because this will come up again, and it's not in any other slide after this, but an antalgic gait has a shortened stance phase of gait. So if they're on the normal leg longer than they're on the abnormal leg, it's due to pain. If it's due to muscle weakness, they've got to stabilize themselves, and that's why you always think of it as a hip, that they're trying to get their hip joint lined up with their knee, lined up with their ankle, and so they lean into it. So it's a prolonged stance phase of gait. And through your through your foot and ankle stuff, you'll learn more about the phases of gait. But this is a shortened stance phase of gait. By definition, is an antalgic or painful gait. A prolonged stance phase of gait is a Trendelenburg or weakness gait. So, palpation, you got to have your system. You'll learn my system when you're in my clinic. You'll learn other people's system when you're in other people's system. You need to know your surface anatomy, and surface anatomy is a grossly underplayed or underemphasized part of this. You need to know where the patella is, where the tibial tubercle is, where the medial joint line is, where the fibular head is, where the medial epicondyle is, where the medial or the lateral epicondyle is, and that's the definition of surface anatomy. You need to know where the AC joint is in the shoulder, where the acromion ends, where the scapular spine is, where the coracoid is. So knowing your surface anatomy, and if you need to, you get used to just start drawing this on patients and being able to what's that G right there? Right, and what goes to Gerdy's tubercle? Yeah. So the iliotibial band, that's one of its insertion points, is Gerdy's tubercle, not its sole insertion point. And that's also right around where the ALL attaches too. So very close, usually just a little bit posterior, a little bit more proximal than Gerdy's tubercle for the ALL. So Have your system. I tend to go not to where it hurts right off the bat. I'll have my systems to make sure that I don't miss anything. I'll usually start on the medial side, have them flexed up a little bit to touch medial femoral condyle, touch the medial joint line, touch the or palpate the insertion of the superficial MCL, touch the pes tendons, go up to the medial joint line, touch posterior medial joint line. So now I've got anterior medial joint line, posterior medial joint line. I'll touch patella, I'll touch distal polar patella, I'll touch patellar tendon, I'll touch tibial tubercle. Then I go to lateral joint line, Gerdy's tubercle, fibular head, lateral femoral condyle up here. And then posteriorly we'll go into the medial and lateral heads of the gastroc, and we'll go into the popliteus, which is just behind the biceps tendon back there. Does that make sense? Origin is going to be anterior to the biceps tendon. The bulk of the popliteus is behind the biceps tendon. So have your system and practice on each other. Just making sure in your mind, when you practice on each other, have something that's going to hurt and see if they pick it up on you. Because they will miss something, they'll forget something. I'm complaining of medial-sided, I'm coming in complaining of medial-sided knee pain, but in your mind, my popliteus is what hurts, and see if they can find it. It's the best way. In medical school, that's what you have, are these knee models that are actual people that are coming and getting paid for you to examine them. So you just go through your medial side, your anterior side, your lateral side, your posterior side, and this is just everything we talked about. Again, we just keep drawing out surface anatomy. That's the first thing. Anybody who's been in the OR with me knows that's the first thing I do is grab a pen and draw my surface anatomy. After all these years, I'm still going to draw where the patella is, where the tibial tubercle is, where the patellar tendon is, where the medial joint line is, where the lateral joint line is, where the fibula is. And so patients will always see that the next day when they're taking off the dressings and what did you do to me? So, and that's just fine. That washes off pretty quickly. So range of motion in the knee. So palpation or inspection palpation. Now we're putting through a range of motion in the knee. We tend to do passive range of motion for most knee issues because they're lying supine. In the shoulder, we tend to do active range of motion first, but just know your system. There's no one right way or wrong way to do it, but you need to know both what their active range of motion is and their passive range of motion. For me, it's just easier for me to put them through a passive range of motion about the knee because I can tell where pain is and symmetry to the other side. And if I can't get them passively, they're not going to be able to get it actively any further. So in the shoulder, I'll have them go actively, and they might get it to 140, but I want to know, is it stuck there, or can I get it further? So there are reasons behind the madness on that. So you want to assess the pain during the end range of motion on these, and then how do we describe these range of motions? It says right in front of you. How did we describe the range of motion of a knee?
Rest and flexion. It's like so say if they can't get into full extension, you would be 0 and then maybe 10 degrees and then whatever.
Right. So calling it negative or plus or anything like that is super confusing to everybody. People who've been doing this 25 years, it's confusing to us. So we eliminate the 0, the plus or the minus or anything like that, and you just have a 0 in there somewhere. The 0 is just fully out straight, for example, for a knee. So if they hyperextend 10 degrees and they bend to 140, it's 10, 0, 140. If they're 10 degrees short of full extension passively, then it's 0, 10, 140. But you also got to be able to say their range of motion is 0, 10, 140 passively. And actively, it's less than that, something like that. When will active range of motion be greater than passive range of motion? It won't. So your active range of motion will maybe equal to your passive range of motion, but it'll never be greater. So decreased active range of motion, but normal passive range of motion is most likely going to be a muscle or tendon type of problem, quad tendon tear, patellar tendon tear, something like that. Decreased active and passive range of motion is really only two things that can do that. It's either the bony architecture, meaning arthritis, or loose body or something like that. It'll be soft tissue constraints in the shoulder, such as adhesive capsulitis or frozen shoulder. So as it really is pretty easy as you, don't make it overly complicated. If passive range of motion is less than or is greater than active range of motion, there's only two reasons. So strength testing, we went through this the other time. Give yourself the advantage of a lot of times the patients, especially in our athletes, are going to be larger than you. And how can you really tell the difference between 4 and 5 if they're bigger and stronger than you, because you can't overcome them. So sometimes you have to give yourself the advantage, although you may want to test their quad strength out closer to straight because that's where they're the strongest. They're going to be weaker in flexion, so you may need to test it more in flexion like this so that you have a little bit more of an advantage. Does that make sense? And this is what we've talked about. This slide in particular, you guys should have nailed down somewhere. 0 to 5. It's easier to go from the bottom of this slide up than it is from the top down. 5 or 5 is full range of motion against full resistance and equal to their symmetric to the other side. Full range of motion against some but less than full resistance. So anything less than the contralateral side is going to be 4 out of 5. So just like we talked about with articular cartilage or ligament issues that are often grade 2 AMA, because that's such a large spectrum. 4 out of 5 is such a large spectrum. More often than not, you'll see this 4+ out of 5 just because 4 out of 5 is the bulk of everything. Nobody's ever defined what plus is or 4 minus is. So if you just say 4 out of 5, it's a pretty large spectrum. 3 out of 5 means you've got full range of motion, active range of motion. This is all strength testing, so it's active against gravity. Now, if you eliminate gravity, and we did this the other day when we did eliminating gravity for the elbow was doing this with your elbow horizontal against gravity is going to be like this. So this, you can do full range of motion like this against gravity, but no other resistance. That's going to be 3 out of 5. If you can apply a little bit of resistance and still have full range of motion, but it's less than the other side, that's going to be 4 out of 5. If you can't do full range of motion, it's just partial range of motion against gravity. But as soon as you eliminate gravity, put their elbow on the tabletop, and they have full range of motion, that's going to be 2 out of 5. So, and then if you've eliminated gravity and they still can't do a full range of motion, so remember, it's not just seeing it move, it's a full active range of motion with gravity eliminated. Is 2 out of 5, and then if they can't do full range of motion with gravity eliminated, it's just 1 out of 5, and then 0 out of 5, you're not even seeing a flicker. So if you're seeing it fire, but it's not moving at all, that's 1 out of 5. If it's moving, but not full range of motion, that's 1 out of 5. So does that make sense? So let's go through just some of the specialty. There's a billion specialty exams. These are far and away the 3 most common that you might see in I knew it, right? You put in these videos and they're not there. So a Lockman exam, you're putting the knee in 20 to 25 degrees of flexion. You're stabilizing the femur with my hand, so I'm not moving that right hand at all, and all I'm doing is putting the left hand behind it and pulling it forward. That thumb is on my left hand is immaterial on that body. I can just have my palm, because oftentimes that tibial tubercle might be tender to somebody, and so having that thumb there can be counterproductive. Same thing with the right hand. All you're doing is trying to stabilize the femur. You don't need to squeeze it as hard as you can. You don't need to push it backwards. Anything else, all you're doing is trying to move differential motion of the tibia on the femur in about 20 to 25 degrees of flexion. Oh, there you go. Okay, you got it. So there you can see, and the only thing we're testing is we've taken made everything else lax. So the only thing we're testing with that is the ACL. So originally described by John Lockman, who was the chairman of the Department of Orthopedics at Temple University, published by his colleague Joe Torg, who you guys all know Joe Torg from cervical spine issues in football. The Torg ratios, you probably remember, of cervical stenosis. Joe Torg was really more of a spine guy, but he published that for John Lockman and named it after Dr. Lockman. So you hold the knee flexed in 15 to 25 degrees of flexion, stabilizing the femur at the level of the tubercle with the other hand. Translate the tibia forward. And this is schematically what you're doing with that. And then the Lockman you need to compare to the other side. It's specific, but not very sensitive for ACL insufficiency. What the heck does specific but not sensitive mean? What's that? Don't look at your glasses. Why? So it's specific. What does that mean?
Should be able to test with that issue. So like if someone doesn't have, say if someone doesn't have an ACL, like that's the specificity, but the sensitivity is able to identify the injury.
So it has to do with false positives and false negatives, but let's not get into that. Let's just be a lot more general here. If the Lockman is specific but not very sensitive, that means that if you have a positive Lockman, they have torn their ACL. But having a negative Lockman does not necessarily mean they didn't tear their ACL. Does that make sense? So a sensitive test, ideally, would have the exact opposite, meaning anybody who tore their ACL would have a positive test. But there would be other reasons why you might have a positive test if it's very sensitive. So you don't mind having a bunch of false positives on a very sensitive test. Does that make sense? So a very sensitive test for lung cancer is, can you breathe? Everybody who has lung cancer can breathe. How's that? But there's a heck of a lot of other people that can breathe that don't have lung cancer. So that's a sensitive test, but not specific in the least. Ideally, tests are both sensitive and specific, but but a specific test for lung cancer is a biopsy showing cancer cells. But that's not very sensitive because not everybody has had a biopsy showing cancer cells. So a Lockman test, and so why would a Lockman test be specific but not sensitive? What's that? Right, there's several reasons. Guarding is going to be one of them. A big effusion, they come in just tore their ligament 4 hours ago. May not even be guarding. You may be able to get them to relax, but a big swollen knee prevents it from translating. A bucket handle tear is just locking that knee down and you can't move it. And so we'll tell people that all the time that they're coming in with a big swollen knee, just blew out their knee, and Lockman doesn't feel that bad, but they could have a bucket handle tear of their knee, and that's one of the reasons why we need to get an MRI on that big swollen knee, even though it doesn't feel loose to me. So it could not be loose because they didn't tear their ACL, or it could not be loose because they have something blocking it, loose body, meniscus tear, big effusion, things like that. Does that make sense? So here, lots of good examples, and you guys should all have in your files different little videos. Now what's this? There you go. So let's go, what's a pivot shift? Or how do you do a pivot shift? Let's talk about that. Let's not talk anatomically what a pivot shift is doing. How do you do a pivot shift? Do you know? Anything you do, you better be able to explain or you don't really understand it, is my philosophy. So here's easy. So you slightly flex the hip a little bit. Your knee starts off extended, internally rotated with a valgus stress. Let's go back to this one and you'll see, oops. So you'll see that we'll do that here. So given it valgus, extended, internally rotated, boom, that's your pivot shift. So hip slightly flexed, internally rotated, valgus, and then you go from extension to flexion, and it clunks. Now we get to the hard part. What is actually happening in that knee? So that's it. Just get to know your position when you want to do a pivot shift. This is super important. Knee is extended. Valgus stress. Internally rotate the foot. So going from extension to flexion, the knee will clunk if the ACL is torn. And the reason for that is the IT band is pulling the dislocated tibia back into place. So it's actually dislocated back in this position when we start off, as soon as we go into valgus, internally rotated. Now it's dislocated there, and now it'll relocate there. So it's dislocated, relocates. So people early on when they're learning this, they think it's the opposite, that it's going from a reduced to a dislocated position, but it's the other way around. You're actually dislocated and then coming back into a reduced position as you flex. Make sense? So going from extension to flexion, the knee will clunk if the ACL is torn. The IT band pulls the dislocated tibia back into place. Originally described back in 1980, so it's not all that long ago compared to the Lockman by Galway. It used to be called the Galway exam. Gary Losey was the other guy who wrote it up at the same time. These people were in Galway was France. Losey was in, I think, Wisconsin at the time.
Shooting.
So same type of thing. You go from valgus, internally rotated, dislocated, reduced. Valgus, internally rotated, extension, flexion. So as you start to get to know kind of what anatomical structures are happening, it makes more sense why you would go internally rotated, because at this level, you're going to go, God, I forget, did Dr. Sterett say I externally rotate or do I internally rotate? Did I go into valgus or do I go into varus? So as you understand the IT band, you're going from a dislocated position to a reduced position, and the only way you can do that is internally rotating the IT band, is pulling it forward, and then as you flex it up, the IT band just gets pulled. Because as you're flexed, the IT band falls below the level of action of the joint. Does that make sense? Again, same thing here. All right, what's McMurray's maneuver? What is that? Not what it shows, not what it's diagnosing. What is it? You can either tell me what you do to do a McMurray's maneuver or why it tells you or what it's doing anatomically in there. Your choice. You can pick the easy one.
Put them in deep flexion.
Okay.
And just kind of around their leg, back and forth.
You're really thinking our anatomy books, this is just kind of move around the leg.
Well, so I know that it's like you do internal and external rotation.
Okay, those are way better words than just kind of move around the leg.
So
So
Ryan told us that those don't matter as long as you just like move it around and they're positive.
If every surface. We want to try and compress.
so okay, let's you guys all need to understand, just like you understand where the Lockman exam came from, who Lockman was, where the pivot shift came from, why it's called pivot shift, not after a guy's name, because two different guys described it about the same time. So McMurray was a guy in the 1920s who described this exam. So well before MRIs, well before arthroscopy, and what he was describing is still, to this day, we can't get an insurance authorization approved for a meniscus tear unless we have a positive McMurray's, which is goofy. We can have patients complaining of locking, catching, swelling, and an MRI shows a meniscus tear, but unless we write in the clinic note positive McMurray's, we ain't getting it approved. So McMurray's maneuver was described in the 1920s, and it was thought back then, diagnostic of a torn meniscus. Nobody had any idea that the meniscus was an important part of the cushion of the knee. It was actually described more as a remnant extension of the quadriceps muscle and wasn't of much value at all. So if you tore the meniscus and it was symptomatic, just make sure you take the whole thing out so it can never tear again. So you flex the knee up maximally. That's stage one, just like with the pivot shift, you extend the knee maximally. And then with one hand on the joint line, the other hand holding the foot, you slowly extend the knee while internally rotating the knee. And then you go back into flexion and you repeat while externally rotating the knee. So you're going from flexion to extension, once with the knee externally rotated, once with the knee internally rotated. That's how it was described. In a positive test, the examiner will experience a palpable or auditory click during rotation. It had nothing to do with symptoms of the patient in the original McMurray's maneuver description. It was just a palpable or auditory click. So in practicality, we use it if it's recreating their pain in deep flexion or recreating their pain. We actually don't really pay much attention to the noises that it makes, because you may make noises on both sides, but it doesn't necessarily make it a positive McMurray's. In reality, it should be considered a positive McMurray's, because that click is probably because it's a hypermobile meniscus that can create that click, but if it's not symptomatic, you're not going to operate on them. So that would have made it a positive McMurray's all the way until MRI time back in the 1980s. But now we functionally just use it as a pain, and especially if they get a sharp stabbing pain, you know, like it's jumping into place or jumping out of place. And all you're doing is trying to squish that meniscus in between, the posterior horn of the meniscus in between the femur and tibia with some rotation. And that'll usually, if it's a flap tear or something like that, get it to reduce or get it out of place, and it can be either one. So this is how you'd look at a McMurray's test. You flex it all the way up and then internally rotate and go to extension, or externally rotate and go into extension. Does that make sense? So those are the three big takeaways just on physical exam from here. Is going to be pivot shift, Lockman, and McMurray's maneuver. But each one of our specialty exams has a different origin to how it came to be and who did it. And I find all that stuff fascinating and fun to learn. So other specialty knee exams, you know, patellar translation or apprehension, the quadrants of that, you know, valgus stress, varus stress, reverse pivot shift, posterior drawer, pain with extension, pain with flexion, duck walker, squat, varus thrust with gait. All of those we could spend a whole hour talking about, breaking each one of those down, but we just run out of time. So these are some of those other specialty exams talked about. So documenting. Now we'll just spend a little bit of time, because I'll bet we're starting to run out of time a little bit, but we'll be okay. So there's two different ways of documenting these knee ligament exams. And it's really not even necessarily as important about the documenting as describing. So the IKDC was originally back in 2000, actually a little bit earlier than that, the first generation of that, but the International Knee Documentation Committee came up with this classification scheme, and there's a subjective form and an objective form. We're now getting to the point where publishing, we really only need the subjective form, which is fascinating, because for 30 or 40 years, you weren't allowed to publish unless you have the objective form, a 2-year follow-up on all these. And so there's been so many studies showing correlation between subjective form and the objective outcomes of these, that as you can't get patients back into the office at 6 months, 12 months, and 2 years, you can just do it with the subjective form. But we're mostly going to go through the objective forms of the IKDC. The Moon Group was a national group of high volume ACL surgeons that pooled all their data, and we've learned a whole ton over the last 10 years about kind of who tears their ACL, who re-tears their ACL, what are the risk factors, what are all sorts of things. And this is IKDC is what they adopted for clarity, and so that's why if we're going to be describing this to other healthcare professionals, you really need to understand IKDC. This is looking at it far away, you won't be able to read too much of this, but it's got the top part of the form. Oh, I didn't know I had that stupid McAfee up there. You know, just all the demographics of the patient, and then realistically, they describe it as 4 different grades. A is normal, B nearly normal, C abnormal, and D severely abnormal. Whoa. Okay. You know, that you can classify those as grade 1, 2, 3, and 4, or 0, 1, 2, and 3. But that's how the IKDC did it. And then we'll look at these a little bit closer. And but all of these have to look at, you really should spend some time going over this in the clinic, because so many of these, most of them will say delta. And delta means you're comparing it to the other side. So a Lockman is described as a delta, meaning not how much translation you have, but what's your delta. And how much delta means that you torn your ACL, not how much actual translation. And there are numbers on the Lockman exam that absolute translation will be indicative of an ACL tear as well, but on the IKDC form, it's going to be a delta. So this is hard to do in a slide format like this, but it's really important for you guys to just sit down and go through each line of this with each other to get to know what because each one is super important. It should become second nature, although it can be a little bit daunting when you first start looking at it. So this has a pivot shift, and even on the pivot shift, it's a delta pivot shift on this form, which is a confusing thing to all of us. So if we saw that pivot shift video, and that was a clunk, or maybe even a gross clunk, but if it was a gross clunk here and a clunk on the other side, then the delta is just a glide, which makes no sense. So, so most of us will still put the pivot shift as just an absolute, clunk, gross clunk, or glide are the three most common. So how about the AMA classification? I'm giving you because we're running out of time that there is an AMA classification. What's another classification of ligament injuries? It's what you guys came here knowing. Sure. What is that?
Grade 1, it has a firm endpoint. Grade 2, a soft endpoint. Grade 3.
So it's just a physical exam finding, grade 1, 2, and 3 for ligament injuries. Answer is no, or I wouldn't have asked that. So it has to do with both, it's an anatomical finding as well combined with a physical exam finding. So, and here's what you can see is if this is a ligament and this is normal, a grade 1 sprain will have some intrasubstance damage to this ligament, but no change in their physical exam. So they will be tender, but a normal ligament exam. So an MCL that is tender but is equal to the other side, that would always be a grade 1 sprain. A grade 2 sprain has some tearing but not complete tearing, and so they will have some increased laxity and as well as tenderness if it's an acute injury, but they will have an endpoint. Firm, soft is a whole different thing about this. And the grade 3 sprain is a complete tear of that, so they will have much more laxity and won't have an endpoint, whether it's ACL, MCL, PCL, or even LCL. That's the end, or whether it's the lateral ankle ligaments as well. This is the most common grading scheme, and you're going to hear about this from ER docs. You're going to hear about this from family practice docs, and you guys will even use this down the line because it's the easiest thing to understand. But you need to get better and better as you go through this year with your IKDC classifications about, a grade 1 tear of an MCL or an ACL on the IKDC is 2 to 5 millimeters of increased translation. 5 to 10 millimeters is grade 2, and greater than 10 millimeters of increased translation relative to the other side is a grade 3. Whereas this, this is just easy to understand, but a lot more vague. Almost everything is going to be a grade 2. You're never going to go wrong saying it's a grade 2 sprain of MCL or ACL or something. Yeah, I thought I could feel an endpoint, or it wasn't that loose, and it might be not that loose because they had a big effusion or all the other things we talked about. So this combines inspection, palpation, range of motion, and specialty test, 5 millimeters of increased opening with valgus stress, tender over the medial femoral condyle, minimal swelling. That would be a grade 2 proximal MCL tear. So you can go to both anatomical abnormalities as well as physical exam findings with an AMA classification and IKDC to a lesser extent. But that provides both diagnosis and prognosis. If you have a grade 2 proximal MCL tear, you know exactly how it's going to take 3 to 4 weeks for it to heal, but it should not need surgery. If you just said it's a grade 2 MCL tear, I've got a lot more information I need. So they were tender over the medial femoral condyle. If they're tender over the distal MCL on the tibia, 6 centimeters below the joint, and they have grade 2 opening, that's a much more concerning thing. That may not heal without surgery. The distal MCL tears tend not to, and so that's when you need an MRI, is if they're where they're based on whether they're tender, with the otherwise an exact same physical exam finding, and they're both grade 2 injuries. Does that make sense? So it's easy to understand. It's much more general. Most injuries are grade 2. Example, MCL sprain, just like we talked about. But you need to be able to classify this through both IKDC and AMA, and you need to ask your colleagues when they're presenting something to you as a grade 2 MCL tear. You say, well, is that, are you talking about AMA or are you talking about IKDC? Because a 2 to 5 millimeters of increased opening relative to the other side is a grade 1 on IKDC, but it's a grade 2 AMA. So, does that make sense? So it's not bulletproof and not super straightforward all the time. So you just now that you know everything, you just need to practice on it with each other. You know, be your own knee models. Know in your mind where it's going to be tender. You may not be able to create laxity just as knee model, but you can certainly get to know, you know, go into it in your mind where I'm going to be tender, where I'm going to, or maybe I'm weak in my quadriceps or something like that. I'm going to try to fake a positive McMurray, see if they can pick it up. And you need to have your whole system down: inspection, palpation, range of motion, strength testing, and specialty tests. And you go through it in your mind, and then you present it in the exact same order of what you did. And if it's all a bunch of normal stuff, you don't always need to present normal findings, but you can say physical exam was entirely normal with the exception of a positive McMurray's in extension. Now, I may quiz you and say, did you really do a Lockman? Did you really do a pivot shift? How did you do that? How would you find? And once we get to know each other, and I trust that when you say the physical exam was normal with the exception of they were black and blue on the medial side of the knee, I'm trusting that you've already done your valgus stress testing and Lockman and all that kind of stuff. So